Thank you again for the opportunity today. So I'm going to start discussing a little bit about, the agenda in a bit, but these are my disclosures. So we'll talk today about diffuse large B-cell lymphoma. The general agenda will discuss a little bit about the upfront management of DLBCL to start with, and then go to relapse refractory disease. And some of the points we'll try to cover today are attempts to improve upon R-CHOP, discuss a little bit about cell of origin and its significance, approach to limited stage elderly and frail patients, attempts to predict CNS risk and CNS prophylaxis use as well. And then in the relapse refractory space, we'll talk about some second line approaches, where CAR-T is today, and then talk about novel agents and immunotherapy. All right, so we do have a lot of slides, so if that's possible to just, alert me when it's like 15 minutes to ending it, I'll try to pace myself accordingly. So I think this is very, something that's not unfamiliar to this audience. This is the most typical non-Hodgkin lymphoma with an estimated 150,000 new cases annually worldwide. The median age of diagnosis of DLBCL is in the mid-60s, so around 30% of patients are older than 75 years of age. And patients typically present with progressive lymphadenopathy. There's extranodal disease as well, or both, and they both require therapy immediately. And despite the aggressiveness of the presentation, more than 60% of the patients can be cured with frontline chemoimmunotherapy. And those who experience treatment failure, they're treated with second-line chemo and autologous stem cell transplant. However, refractoriness to frontline chemotherapy does portend a pretty poor prognosis. So when we talk about diagnosis of DLBCL, the detailed examination of tumor tissue is very key. So we always recommend an excisional biopsy. An FNA or a core biopsy generally is suboptimal. A core biopsy is better than an FNA, but we may still miss some of the architecture. So large cells with a lot of sheets of large cells, basically with loss of follicular architecture of node, is what we commonly see in morphology. The typical immunophenotype is a CD20 expressing tumor, also expresses CD45 and usually CD3 negative. In the IHC, we look for BCL2, BCL6, and MYC expression as a standard to be able to estimate the risks for these patients. We also look for CD10, BCL6, and MUM1 to estimate the molecular subtype. I'll talk about a little more in the next couple of slides. And we perform a FISH evaluation for BCL2, BCL6, and c-MYC rearrangements. I'm sure this was covered in previous topics, so I'm not going too much into this. And something that's not done in actually most centers here is gene expression profiling testing. It's available at a few centers here. This is a non-standard for cell of origin testing. It's important, though, in any talk of large cell lymphoma to remember still the International Prognostic Index. The IPI score has been around for around 25 years and remains still the primary clinical tool for predicting outcomes for stratifying patients in clinical trials. And this has been modified and refined in the, can you hear me okay? Okay, I'm going to keep going. This has been modified and refined in the modern era with the NCC and IPI that allows for greater discrimination amongst patients. So every so often we see patients in clinic with high IPI score, and unfortunately we don't have any way to use the IPI yet to treat these patients any differently. So I think it's a bit sobering to know that we can have a prognostic score so robust and yet very little way that we can actually measure the impact of the IPI on patients' outcome and then change treatment, So this group likely knows now that the general large cell lymphoma treatment paradigm standard of care is R-CHOP 21 or R-CHOP every 21 days. And what you see here in front of you are studies that are done in older patients, young patients, all showing on the left PFS and then on the right overall survival improvement with the addition of rituximab to CHOP chemotherapy. So in the modern era, we would estimate that we cure between 2/3 of the patients or up to 70% of all patients with DLBCL. And as far as we can see, there's actually obvious room to do better, right, as far as curing patients. However, this has been particularly challenging. So the focus of the next part of the talk would be to talk about ways that we've been trying to improve upon our CHOP, where we've not had success and where we may have had a little bit of success, and moving forward, certain subtypes where you may see, if you see these patients, you may want to do something a little bit differently. So before we get to that, when we see patients in clinic, one of the two things we look for are can the patient receive 6 cycles of R-CHOP? Like there are patient features, some of them I've mentioned here, mainly comorbidities and performance status, and general other medical issues. And there are disease-related features in terms of stage, the location, are there extranodal sites, what's the molecular subtype, and basically also looking at FISH studies. Now that we know that actually since 2001, we've had dozens of randomized clinical trials trying to improve upon R-CHOP given every 21 days, whether it's R-CHOP given every 14 days, including upfront stem cell transplantation in CR1, maintenance of rituximab even after chemotherapy, and including then a number of these other agents listed here in addition to R-CHOP, unfortunately have really not led to any positive results. I'm going to talk about at least some of the info here, at least those are thought-provoking on a couple of these studies. Particularly the last 4 are relatively new. And dose-adjusted epoch are particularly useful in a couple of situations. And I think the other ones are also a bit nuanced, so I think it'll be useful to talk about them. And finally, the R-CHIP plus polatuzumab data that's come out has been pretty exciting, so we'll shed some light upon that. So first, the Alliance CALGB 50303 was a randomized phase 3 trial that was published a few years ago that compared R-CHOP versus dose-adjusted R-epoch. This was like, a very exciting trial that everyone's been waiting for because we all wanted to know whether there's any utility of using epoch upfront for patients with untreated DLBCL. So randomized trial, and epoch, as we know, is an infusional regimen that's more complicated. There's more toxicity. The idea that this could actually improve efficacy based on the dosing pattern of the regimen and the addition of etoposide was sort of the glimmer there. But so we wanted to actually assess this in a trial, and the primary endpoint in this case was event-free survival with standard secondary endpoints. But unfortunately, if you look across the board, while there were a few nuances, it's safe to say that there was no clear difference at all of improved PFS or overall survival with the use of dose-adjusted R-epoch over R-CHOP. We'll come back to this a little later. There are a few subsets where there may be a hint of use of this regimen being useful, but we do not have any definitive information at this point to suggest that dose-adjusted R-epoch across the board is worth the toxicity in a vast majority of the patients. So R-CHOP still based on this would be kind of standard of care between these two regimens. Now coming to cell of origin, there's been a great interest in studying the molecular biology of DLBCL, and I'm not going into too much into detail because of the length of this talk, but gene expression profiling in general has helped really identify different distinct molecular subtypes of DLBCL. So namely the germinal center B cell and the activated B cell subtypes. These have been around for around 15 years. And these subtypes are believed to arise from different stages of the lymphoid differentiation, that is the cell of origin, and they rely on specific oncogenic mechanisms. So the ABC subtype of DLBCL is actually characterized by chronic B cell receptor signaling and activation of the NF-kappa B pathway, whereas the GCB subtype, they express genes that are commonly detected in germinal center B cells, including BCL6 and EZH2. So although gene expression profiling is rarely performed in clinical practice, as I mentioned, there are alternate surrogates used using immunohistochemistry, such as the Hans algorithm. Sorry about this. The Hans algorithm, which uses a combination of CD10, BCL6, and MUM1, and that's the reason we study these stains on IHC, and we use this in an algorithmic fashion to help differentiate patients in clinic to the GCB or non-GCB subtype. So what's the significance here? Retrospective studies are actually available with gene expression profiling again, showing that the germinal center subtype actually has a much more favorable outcome than the ABC subtype. So again, looking at how the ABC subtype does, that stimulated a lot of thinking into mechanisms in this particular subtype. So there's a diverse range of somatic mutations that have been identified. I'm sorry for the busy slide, but these are the intracellular signaling pathways that have been deranged and characterize the distinct molecular subtypes of the disease. Top here, you can see some of the alterations seen in the GCB subtype, and at the bottom here, you can see some of the mutations seen in the ABC subtype. So the next major breakthrough in DLBCL during the molecular era of the disease would really be the identification of combinations of novel agents that would target some of these oncogenic drivers of these subsets. So as you can see, some of the targets that you've heard of during the course of this meeting, these are the BCL2 translocation, there's EZH2 mutations. These are areas where we could target in the germinal center subtype, for example, whereas, in the ABC subtype or non-GCB subtype, there's pathways in the NF-kappa B or MYD88 or CD79B. Those are some exciting, targets that we could look at. So the idea is to take one of these subsets and then add to the R-CHOP a drug that may be relevant and that could target a specific pathway in the subset, and particularly of interest in the ABC subtype, where the outcomes are less favorable with R-CHOP in general, as we've seen. So taking that forward, over the last few years, we've had a number of, pretty admirable attempts at targeting the ABC subtype pathway, which unfortunately have been unsuccessful. So one of these trials I'm showing here is the Phoenix trial, and this trial combined ibrutinib, which has particular activity in the NF-kappa B pathway, and hence in the ABC or non-GCB subtype. And this trial looked at non-GCB DLBCL alone, and patients were, they used IHC-based, classification as well as GEP, like gene expression profiling, and they randomized them to receive 6 to 8 cycles of R-CHOP versus R-CHOP plus ibrutinib, and using EFS as the primary endpoint and other standard secondary endpoints. So what we see here is that, the primary endpoint being EFS, if you look at this, whether it's the intent to treat population or the ABC subtype, you see no difference in the whole population. And there was also reported more toxicity with ibrutinib when added to R-CHOP, especially in the elderly patients on the trial. However, if you look at young patients, namely when we define that as less than 60 years, that was retrospectively designed and defined in this trial, there was a little bit of glimmer of interest here. So ibrutinib seemed to have some value, and this can be interpreted in a number of different ways as to why this may have happened. One thing is, some would speculate that the older patients on the trial had a lot more toxicities with ibrutinib, and that was the reason for the inferior responses, and that the young patients were able to tolerate it much better, so they did better and reap the benefits. However, the problem is that these cutoffs were retrospectively defined. Some of these subset analyses were sort of done retrospectively designed, so that come with their own limitations as to how you would interpret results once the trial is published. So that's one of the reasons why this remains an open question at this point. Some people are pursuing this strategy and some are not. There are also some other clinical trials that are looking at second generation BTK inhibitors. Acalabrutinib, for example, is a better tolerated BTK inhibitor seen from our experience in CLL. So those are being studied in combination with R-CHOP in a randomized fashion. And hopefully those will help shed some more light on this in the future, especially with related to the toxicity profile, and seeing if that offsets some of the negative effects that we see in Phoenix. Another area of interest with respect to the non-GCB subtype is with lenalidomide, and this also has its role in the NF-kappa B pathway. So this was a randomized phase 2 trial, ECOG, SWOG, Alliance together doing this, taking patients with large B-cell lymphoma and randomizing them to 6 cycles of R-CHOP versus R-CHOP plus lenalidomide. And they use gene expression profiling, mainly nanostring, to determine the cell of origin, and hence the ABC subtype, specifically the term being used here. The primary endpoint here was progression-free survival in all comers, and they had a co-primary endpoint of progression-free survival in the ABC subtype. So these were the results. These were quite interesting in that the R-squared CHOP was associated with actually better PFS, whether you look at all the patients or you look at ABC subtype. And again, this was determined by nanostring or gene expression profiling that you see some of these numbers. This was exciting, of course, but remember that this was a randomized phase 2 trial, which is important. And this is the reason why it's important, because at the same time was presented this large randomized phase 3 trial, the robust trial, This was conducted in untreated DLBCL patients, again focusing on the ABC subtype, but in a phase 3 randomized fashion. And these were, again, the ABC subtype patients were identified using nanostring. And only the ABC subtype was randomized here to R squared CHOP versus placebo. And unfortunately, in this trial, we didn't see the difference that we saw before, right? So there's no difference in the R squared CHOP and R CHOP, and this was sort of delivering a final nail in the coffin, if you may, for R squared CHOP based approaches, because this study was, people were heavily banking on this. So, what may be the explanation of one trial really not showing the difference versus the previous trial showing? So the possible, reasons that were postulated here, there were differences in the identification of the subsets. Some of them were, again, retrospectively defined. The location of where the patients were treated also was different. There was some difference in the dosing of the lenalidomide between the trials. The robust trial actually used a lower dose of lenalidomide and actually slightly differently scheduled as well. On the phase 3 trial, the diagnosis to treat interval was also around a month, the robust trial, whereas in the phase 2 trial, it was only 22 days. So from everything we know about large cell lymphoma, diagnosis to treatment interval becomes very, very key, and it actually correlates with outcomes as well. So those may have been some of the reasons why we didn't see some of these differences. All in all, the data has not been compelling at this time for the addition of lenalidomide to R-CHOP for GCB DLBCL. So in the last year, there's been a lot of excitement in the upfront space, with finally maybe a glimmer of hope of something potentially beating R-CHOP. So this was the POLARIX trial that randomly assigned patients to receive polatuzumab, which is a CD79B antibody drug conjugate that has a toxin MMAE, which is an antitubulin at the back. And this was combined with rituximab and CHIP, so removing vincristine because of the neuropathy effect. And this was compared randomly to in a randomized fashion to CHOP. So the primary endpoint here was PFS, and with standard secondary endpoints. So what we see here is that at 2 years, we look at the progression-free survival. 76% of those patients receiving polatuzumab with the R-CHIP and 70% of those receiving R-CHOP alone remain progression-free. So the difference was around 6.5% of polatuzumab adding to the addition of polatuzumab to the R-CHOP, and the trial remained statistically significant, met its primary endpoint. There was a 27% decrease in the relative risk of progression or death with R-CHIP. How about overall survival? We need further follow-up, but as of now, they didn't actually see a difference. And if you look at the two curves, it's hard to see much, coming up, but we'll still, hold our horses there and kind of look at this data a little bit later. The forest plots for this particular study I haven't shown here, but they were pretty interesting and hypothesis generating. They may not be practice changing necessarily, but it's important to talk about those. It's important to note that these forest plots should not really be used to cherry pick, what treatment we use for which patient. But in general, what we saw was the IPI 3 and 4, IPI 3 to 5. So some of the high risk IPI patients generally had more benefit. In general, higher the IPI risk or higher the risk in general, more delta you see with a superior drug. So maybe this was also the case with this particular treatment. And also we saw that in the POLA R-CHIP group, there was also more concentration of ABC DLBCLs. As we know, those are also a bit high risk. So, that was something interesting that we found mechanistically. We don't know why that would make sense for POLA R-CHIP to do better, but, that's something being explored. When you look at the adverse event profile, they were largely similar between the two groups. There was a slightly higher risk of neutropenic fever events with the POLA group. Safety profile was very much otherwise in line with what we get with R-CHOP. Importantly, rates of neuropathy, which is a known side effect from polatuzumab, this was not higher in the R-CHIP POLA as compared to R-CHOP, which was pretty significant. Excuse me. So overall, this is a pretty well tolerated treatment regimen, it looks like. And what was interesting was this was really the first randomized phase 3 trial to show some benefit in first-line DLBCL, which is pretty huge. Can we see a overall benefit? Maybe see overall benefit with follow-up. We may or may not. It's important to recognize now that we have a number of agents in the relapse setting. There's polatuzumab, there's CAR-T, there's bispecifics, and a number of many of these agents that are going to be present for a while, and it's going to be harder to move the needle on overall survival, and likely we're going to need a long time to actually see an OS benefit. So that's something to keep in mind. So just I prepared a summary slide here because this has been there's so much buzz about the POLARIX trial and how does it play into clinical practice and where do we see this evolving. It's important to know that as we saw earlier, many frontline trials in DLBCL have failed. For the first time, this is actually an improvement, so this is sort of exciting for the field. The modest improvement in 2-year PFS between the POLA group versus standard treatment has been a topic of debate. People were like, maybe the 6.5% is not that great. But it also means that some patients actually may need less additional therapy after completion of the treatment on the POLA arm. If you think about this, there's actually less need for maybe additional radiation therapy, salvage second line therapy, maybe stem cell transplant or CAR T. And these are really potential clinical benefits that we see in the trial. So should this become a new standard of care in the frontline management of DLBCL? We don't know. This has to actually go through peer review and maybe also regulatory authority review, of course. And the whole oncology community, all of us, sort of need to digest this data and think about how we would move this forward. Financial toxicity with this regimen has been greatly debated because of the cost of polatuzumab. But if you were to put the cost aside, I think this would be something that's compelling for high risk, high IPI DLBCL. I'm not going to have a study for high IPI patients tomorrow. So if this drug were to be approved in the frontline setting and available, especially with that toxicity profile, I would maybe think about it in the next high IPI patient. I'm not currently using this in my practice today. So who should be treated differently? As we know, with most patients, we're still on R-CHOP every 21 days cycle for 6 courses. So when do you consider treating patients with DLBCL with something different? Some of these scenarios, as we've listed here, double hit lymphoma or primary mediastinal B-cell lymphoma or HIV-associated DLBCL, we've seen a higher utility for, better utility for dose-adjusted REPOC, and the data supports that. If there's concurrent presence of CNS disease, we use CNS penetrating agents, namely high-dose methotrexate with the R-CHOP. Patients with impaired cardiac function, we avoid doxorubicin, as you may be aware as well. So we substitute doxorubicin with etoposide with some of these regimens. For elderly and frail patients, we tend to use our mini CHOP, which is a dose reduction of 50% or so with the R-CHOP. And again, that can be curated and according to the frailty. Limited stage DLBCL, we'll be talking a little bit about this, where we use abbreviated or attenuated courses of R-CHOP, maybe with radiation. So in the next few minutes, I'll talk about a couple of these scenarios where we would consider something different than R-CHOP, recognizing that randomized data with any of these are relatively limited, except for maybe 1 or 2 cases. So starting with limited stage DLBCL, there have been a number of studies to refine the approach. And one of these is the S0014 study that was a single arm study looking at R-CHOP for 3 cycles followed by involved field radiation. And the outcomes look great. So the question is, now that we have PET scans, do we need the radiation therapy? Can we do a PET adapted approach where we can obviate the need for radiation therapy? And here is some data from the British Cancer group. So Dr. Laurie Sain has reported some data on R-CHOP for 3 cycles followed by a PET-directed strategy. So if you're PET negative after 3 cycles of R-CHOP, you get 1 cycle of R-CHOP alone and you're done. And if there's PET positivity still after 3 cycles of R-CHOP, we're treating with involved field radiotherapy. And as we can see, the outcomes are generally, pretty comparable and pretty favorable for obviating or necessarily removing the use of involved field radiotherapy. So this is in practice being adopted by a number of groups, particularly if the patients are PET negative after 3 cycles of RT to avoid radiotherapy. And this has been looked into a prospective way. This is a bigger study that was needed to look into this finding. So the FLIER study was an important study in limited stage DLBCL. The patients who got onto this study were generally less than 60 years of age with early stage disease. Again, they had an age-adjusted IPI that had to be, pretty low or zero, and no bulky disease were allowed to get onto the trial. So this was a randomized trial of 6 cycles of R-CHOP versus 4 cycles of R-CHOP plus 2 cycles of rituximab only. I mean, this is a European study and it was designed in such a way that the 2 cycles of rituximab were a part of the randomization here. Maybe we do things a little bit differently here, but generally, as we can see, these are generally, favorable biology and favorable cases, and this was a general study design. Important to note that this was not a PET adapted strategy, so that's important to know. And we can see in general that patients did pretty well. So we can sort of move away from radiotherapy pretty much in these types of settings. So again, as I emphasized, some of us in practice, we don't do the 2 additional cycles of rituximab at the end. We stop with the 4 cycles of R-CHOP, and we feel that may be pretty reasonable in most patients. Moving forward, there's a lot of attention on double hit versus double expressor DLBCL. These comprise of around 10 to 25% of the DLBCLs. So double hit lymphoma is defined when you have translocation of the MYC as well as BCL2, BCL6, or both, which are triple hit. They're virtually always the germinal center subtype, and their outcomes with standard therapies have historically been pretty poor. Double expressing lymphomas, on the other hand, need to be clearly distinguished. These have clearly dual immunohistochemical expression of MYC and BCL2, and they have an absence of translocation. So it's very important to not confuse them with the double hit. The cell of origin in these cases is usually the activated B cell subtype, and they do have an inferior outcome as compared to other DLBCLs, but not as bad as double hit lymphoma. So these entities are shown here in a Venn diagram, and as you can see here, the ABC subtype owning more of the double expressors, and the GCB subtype owning more of the translocated patients or double hit patients. So the question is how we should treat these patients. So for the double expressor, I haven't shown the data here, but what we saw from the Alliance 50303 is that patients really don't necessarily do better with the REPOC, and that was extensively studied in that trial. And so for double expressors, we largely do R-CHOP for the most part, or a clinical trial. For double hit, there have actually been no randomized trials, and purely based on retrospective data and phase 2 trials, the intent is to do something more aggressive than R-CHOP. Some of these regimens I've shown here have been studied. Some of them are like extremely intensive. So we sort of pick a middle ground, and most of us use dose-adjusted REPOC. And it does better than R-CHOP, but probably not the best. We still feel that this particular subset needs a lot of work. But for now, dose-adjusted REPOC has been the strategy that we've been using with whatever information we have. There are clinical trials investigating novel agents, mainly venetoclax, because of the BCL2 action, has been something that is being investigated in clinical trials, both for double expressor as well as the double hit lymphomas in combination with R-CHOP or dose-adjusted REPOC. So we'll be waiting to see the results of that maybe in the next couple of years. What about older and frail patients? As we discussed, we do an attenuated chemotherapy regimen. So it's a 50% dose reduction of R-CHOP. We also include other strategies like pre-phase of steroids and a comprehensive geriatric assessment before we start treatment on these patients. And depending upon the progression-free survival and depending upon the performance status and the IADL scores, what we see here is that our mini-CHOP is associated with a fairly reasonable outcome in these patients. So this has sort of become the default standard for patients who are elderly, frail, or have like significant comorbidities. There are other studies looking at adding things to the R mini-CHOP, adding drugs to it. So there's a cooperative group study looking at adding azacitidine to R mini-CHOP, and the results of that would be expected hopefully in the next several years, and we'll be looking to see if there's something that can move the needle in that direction. And to wrap up this part, we'll do a couple of points about CNS progression. This has become a major debate and really something that's becoming more and more a topic of high interest in meetings like this. Do you do prophylaxis? Who is at risk, and how likely is a patient to have a higher risk? Okay. In general, what we still use is the CNS IPI. So this was the paper that actually defined more of this. These are a group of like clinical and biological features that we use to um, develop a prognostic model and develop a prognostic score. We use extranodal disease. That's if there's involvement of kidney or adrenals, a higher age, a higher LDH, inferior performance status, and higher stage and extranodal involvement, namely with the kidney or adrenal glands, get higher points. So as we can see here, those patients with extremely high IPI tend to have a higher risk of CNS relapse and pretty significant risk. The question of how to prevent this and the role of CNS prophylaxis that incorporates CNS penetrating agents is still very unproven and extremely controversial. There have been numerous studies in the last 1 or 2 years that have been debating the use of intrathecal chemotherapy as well as systemic high-dose methotrexate. In the interest of time, I haven't shown that data here, but in general, prophylactic intrathecal chemotherapy is becoming less and less favored for patients with DLBCL CNS prophylaxis. Some of us still use systemic high-dose methotrexate, but that is a matter of controversy. We really are using it for carefully selected patients where we feel the risk is, significantly high. But we need better agents. We need some other novel agents and other things to be studied in this particular setting as well. So in the upfront setting in general, what we see is R-CHOP times 6 for most patients, assess the performance status, organ function, and some of these other features to determine if there's need for alternative regimens. We use FISH when it's available, but many a times it's not available for the first start of before we start chemotherapy for the first cycle, and some patients do have a high suspicion of double hit lymphoma per their biology and their presentation. So in these patients, sometimes it's prudent sometimes to treat with dose-adjusted REPOC, and then we change to R-CHOP if the FISH results come back negative. We've had to do that in certain situations where patients present with extremely high-risk features and extranodal presentations and high LDH, for example. We've been using those strategies. CNS relapse risk assessment is very important when we, as a part of diagnosis and staging itself, and appropriately thinking about prophylaxis in those with high risk disease. And of course, after a negative end of treatment PET scan, we monitor clinically and we restrict surveillance imaging or prefer not to use those in general. So quickly, when we come to management of relapsed or refractory DLBCL, approximately 1/3 of patients will unfortunately relapse after initial therapy, and around 10 to 15% of overall patients actually treated with R-CHOP do have primary refractory disease. And the outcomes for those is the median overall survival has been less than 6 months, so really poor. But 20-25% of patients will have a relapse after an initial response, and typically after the first 2 years. So outcomes for those patients are, even actually slightly better. So we'll discuss some of those nuances in the next couple of slides. So if you look at the treatment landscape of DLBCL in the relapse setting, I would say this was pre-ASH 2021, and this looked like this. It was still very exciting to see so many of these new agents being available. So especially if you look at the patients who were transplant eligible, we have a number of these agents that have been, studied and available for use in the second line setting. And yes, CAR-T and some of the other agents here listed were available in the third line setting. So some of this paradigm has been changing, and it's very exciting to see this evolve, in a matter of a few years. And this remains kind of where the field is going. So we'll start with second line treatment for what about the patients who's transplant eligible, right? So if your patient is has chemosensitive disease, treatment with high dose chemotherapy and autologous stem cell transplant still offers the best chance of cure for patients who are chemosensitive. It is important to recognize that, because of advanced stage and coexisting medical conditions, only half of these patients are actually considered to be transplant candidates. And here I've listed a number of these platinum regimens. Really, there's no superior choice. The outcomes in general are all sort of suboptimal. We try to pick the regimen based on the performance status and other comorbidities, and sometimes a little more high risk disease, we try to use something more aggressive if tolerated. But no particular agent has attained superiority over the other or has proven that. The problem with auto, again and again, what we see is its inability to overcome chemotherapy resistance. So if you have patients who are exhibiting those features, it's really hard to get them into remission with any of these second line options, regardless of how aggressive those aggressive those therapies may be. So these patients, we call them, say, transplant ineligible patients, is an important category to discuss. So who are these patients? Who do we say they are transplant eligible? So they actually encompass a group that have patients who are not candidates for autologous stem cell transplant, maybe because of poor fitness, or maybe because of higher age or higher comorbidity burden. Those patients who have an inadequate response to salvage therapy, those who relapse after autologous stem cell transplant as well. So ultimately, a majority of patients with relapsed or refractory DLBCL fall into this category, and these are where the novel agents kind of offer some hope here. So over the last decade, immunotherapeutic modalities have changed treatment landscape, and these are all your monoclonal antibodies, your bispecific antibodies, your CAR T cell therapy, and we're going to talk about some of these drugs going forward. How are we doing on time, by the way?
We have another 20 minutes or so.
Or 20 minutes? Okay, great. Okay, thank you so much.
No,
Um,
I think we don't have three. We have 5 minutes. Sorry.
yeah, that's what
It's
I
like
thought.
my
Okay.
mistake.
Like, okay, then I'm sorry. I'm going to have to then rush to some of these slides. So pre-CAR T, pre-2022, these were the different CAR T cell therapies that were approved in the third line setting. So Axicell, Tisacell, or Lisocell, these have been approved before. In the pivotal trials, they're associated with overall response rates in the range of 50 to 80%. The CR rates were also in the rates of like 40 to 50%, and these were quite exciting. So ASH 2021 was a pivotal meeting for the CAR T world in lymphoma. So there were three randomized trials that were presented: the Zuma 7, the Transform, and the Belinda trial. These were compared to standard of care salvage and autologous stem cell transplant. They all had the same objective to determine whether CAR T cell therapy would improve outcomes in patients with high risk disease over standard of care platinum based chemotherapy. So, largely, the take home point was that Zuma 7 and the Transform trial both were able to meet their primary endpoint and showed superiority of CAR T over transplant with respect to EFS, but the Belinda trial did not show any difference. So there was some discordant, results that we see in between these three trials. So I'm going to show you just the Zuma 7 in the interest of time and the Belinda trial. So this was the trial design: Axicell versus standard of care in patients who had relapsed within 12 months. And as we can see here, Axicell was markedly superior in EFS. Estimated EFS at 2 years were 41% for Axicell versus 16% for the standard of care. It's important to note that only 36% of the patients assigned to the standard of care actually made it to the auto. So this is highlighting the challenge of trying to take patients who are resistant to chemotherapy down a path that relies more on the chemotherapy. So that's something that we see here. The Belinda trial was also designed for patients with DLBCL who had relapsed within 12 months. So this was the pretty much the randomization. Important to know that bridging therapy was allowed for patients assigned to the CAR T cell therapy. Interestingly and somewhat surprisingly, there was no difference in EFS between the two strategies, which was something quite shocking there. So how can these disparate findings be resolved to guide treating physicians? So in general, we don't do cross-trial comparisons, but it's important to consider whether comparable patients were enrolled, whether patients were representative of what we see in routine practices. One thing to note is that Zuma 7 did not allow bridging therapy, that is precluding the participation of patients, those high risk patients who need immediate treatment, right? So in what we've seen in real world trials, that approximate 50% of patients actually need bridging therapy. So this was not representative there, wherein Belinda trial actually had a higher percentage of patients needing bridging therapy. So clearly those were more of the high risk groups. So they were clearly exhibiting a more high risk behavior, and then that's why they probably had some of the inferior responses. So in general, based on some of the results here, we see Zuma 7 and Transform data, Axicell and Lisocell are now FDA approved for second-line therapy in DLBCL. These approvals are restricted to high-risk disease. And some of these unanswered questions still remain, like what do you do for a patient who gets into a CR after 2 cycles of rice salvage? Do you take them to CAR T or autologous stem cell transplant? Some of these questions still need to be answered. I'm going to quickly, in the last couple of minutes, just go through novel treatment approaches. Options for all patients here, aside of CAR T, are POLA-based tafasitamab anti-CD20, anti-CD19 antibody drug conjugate loncastuximab, and bispecific antibodies which are in clinical trials. And these are other agents which are useful in select patients. So this is the POLA data here. I would like to, some of this data we already know about. I would like to maybe skip more to the bispecifics in the interest of time. I'll leave these on the slides for people to see in the future. The bispecific antibodies, these are the next exciting addition to the armamentarium. These are off-the-shelf T-cell redirecting drugs. As we see with CAR T, they've been tremendously useful, but you have to go through manufacturing delays, and there's also toxicities with cytokine release and ICANS. So the bispecific antibodies in those cases are much better tolerated. They activate peripheral as well as intertumoral endogenous immune cells, and they sort of engage the T cells to bring them to the lymphoma cell and attack them through the normal process of killing. So these are the different T-cell engagers that are available now, and we are now in the era of using CD20 directed bispecific antibodies, and these are the different agents that have been used. Mosunetuzumab, for example, the data here is showing the phase 1 trial data shown here, and this is an IgG full-length humanized monoclonal antibody that targets CD20 and CD3. Unique about this, as this was a time-limited study, the ability to stop treatment after 8 cycles for those who achieved a CR. And as we can see, this is a highly refractory population, median of 5 lines of prior therapy. Generally, safety profile is much better tolerated than, I would say, CAR T therapy, with fewer rates of grade 3 CRS and ICANS. And outpatient treatment was possible here as well. Efficacy is pretty interesting in this high-risk patients coming off CAR T cell who are challenging to put on clinical trials. We see actually quite high overall response rates and CR rates. So again, this is quite impressive. Another bispecific, I think we're almost at the end now, which is epcoritamab. This is a different structure using a technology to avoid mispairing between heavy and light chains and to provide a product with a high purity. This is subcutaneous, so the schedule is mostly weekly for the first 3 cycles and then every 2 weeks. Again, a very highly refractory population. This is even more refractory, I would say, than the mosunetuzumab data, which is pretty exciting to see. Again, pretty well tolerated, low-grade CRS, most events occurring during the first full dose. Really impressive overall response rates and complete remission rates in this highly refractory population, including those patients with who had received CAR T and prior lines of therapy, which are median of 4 or 5 lines. So again, very exciting data and durable remissions we see in those patients who achieve a CR with this drug. So these are the next combination studies with epcoritamab in combination with chemotherapy and other novel agents that are in the pipeline to further improve upon this response. And these other bispecific trials bispecific agents in clinical trials. I'll skip this. And so the new paradigm for approaching DLBCL, this is the last slide. What we look at is we start from looking at time from the first line therapy. If the relapse happens less than 1 year, we check for eligibility for CAR T now, which we weren't doing before. And if they are eligible, the preference is to go for CAR T in the second line therapy when available. And if they're not eligible, some of these second and third line options, hopefully bispecific antibodies get added on to this as well. For patients who are relapsing more than 1 year from their initial R-CHOP treatment, we check for eligibility for autologous stem cell transplant at this point. And if they are eligible and they're chemosensitive, we do take them to an auto. And when they're not or relapsed, then we take them to CAR T or some of these other agents here. So I'm so sorry we kind of ran over time a bit and I had to rush through the last couple of slides, but I tried to incorporate a lot of data, which is a drawback of a talk like this. But thank you so much for your time, and I'll take any questions.
Thank you so much, Dr. Suchitra. That was such an amazing talk. So we can have one question from the audience. Before we move to next. Any questions? So, Dr. Suchitra, I feel that bites are biting into the cards now. So, what's going on there? So, do you feel bites will come into play, more often, and they will, become, considered superior to CAR T cells at some point of time in future? Is there some superiority in the bites over and above CAR T cells?
Yeah, I think that's a great question. It's really, I mean, if you look at like why they may be actually even favored at this point, what is really exciting is the rates of CRS and what you see with ICANS, which is really impressive, and and utility more in an outpatient setup, right? So if that translates into toxicity, and if you're considering those as events, I think those would be really very, very useful to see, and generally preferred more than CAR T in that particular setting when available. So again, those things would probably make it preferential. Would they beat CAR T where they are right now in the second line setting is really hard to say. I think obviously we need randomized trials to say that. But generally, what's really effective is the ready availability, right? You don't have manufacturing delays and time there, and the toxicity profile being so favorable, and somewhere the tempt of using this as an outpatient in the outpatient setup is certainly something that's useful.
So thank you so much, Dr. Suchitra, for taking out the time. It's such a privilege to have you in the meeting. Thank you.